Good morning, my name is Anesia, Reticker, and I'm a pharmacist here at the University of Illinois at Chicago, and I'll be presenting with my colleague, Dr. Valdepenas, the updates in transplant medication and technology. We both would like to say that we have no disclosures to present or potential conflicts of interest. So throughout this presentation, I really want you guys to get a good hold on what are the current practices of transplant immunosuppression or anti-rejection medications. You'll hear me say those words quite frequently throughout this presentation, and I hope it makes sense what all that entails, particularly for our kidney transplant patients. We'll talk about some of the different options you have for transplant immunosuppression or anti-rejection medications, and then review some of the updates for transplant medication, in particular some of the technology that now surrounds those. So one good way we always refer to immunosuppressants or anti-rejection medications is remembering that they are a necessary evil but a force of good. Although they can come with some side effects, they're definitely important, and you'll really understand why hopefully at the end of this presentation. So we say immunosuppression or anti-rejection medications. What does that really mean? We have many different medications that have come out throughout the years, and patients you'll see will be on a plethora of different combinations of these medications. Some of the names you might frequently hear are tacrolimus, cyclosporin, belatacept, mycophenolate, azathioprine, sirolimus, everolimus, and steroids. And these are just a few of the medications that we are frequently using to prevent rejection after kidney transplant. You'll notice that, the majority of these medications are oral options, but new to the market, we have seen a movement towards IV medications or intravenous medications that can help prevent rejection in combination with other oral medications. Now, the important thing to always understand is that immunosuppression regimens or medications are always used in combination. And we as transplant providers know that these combinations, there's no right answer. It's more what's right for you. I think the best way to understand that is really understanding that immunosuppression regimens are often like pizza. I'm not from Chicago, but I know a lot of people here in Chicago love their deep dish Chicago style pizza, and that really works for them. I'm from Atlanta, so don't really have a pizza tie to any city, but I find myself reaching for a thin slice far more often. And it's really about knowing what works best for you, and that really applies to our immunosuppression regimens. Sometimes we have different types of sauces, like a white pizza or a red pizza. We might have different toppings, like a vegetarian or a meat lovers. But it's all about finding out what works for you and knowing that that can change over time, and this should always be a conversation with your providers. I hope I haven't made you too hungry because we have about 40 more minutes to go. So what are the different types of immunosuppression? We're saying these immunosuppression regimens, but what does that all entail? Well, we can separate immunosuppression into 4 separate buckets. We have, first and foremost, the desensitization therapies. These are more like what we like to think of for certain patients who are at high risk for rejection. We consider these extra prep or extra preparation in which we really want to get the body ready for transplant, and not many patients require this. We also have the next bucket, which is induction therapies. All transplant patients will receive induction therapies, and these are our big guns in transplant that work right at the time of transplant, kind of blast the body out of all the T cells in anti-rejection ways that it has, and kind of clears the field for the new organ to be placed. After that, we have maintenance therapies, which with these maintenance therapies, which are most frequently our oral agents, these prevent rejection long term. These are life-saving medications, and they really prevent the organ from rejecting and keep it working for as long as the transplanted organ is functioning. You'll need to maintain on these maintenance therapies that do not allow for a missed dose. Additionally, we can have rejection therapies, which are not needed in most patients, but we can see sometimes the immune system can overcome the organ and attack the organ and cause rejection. We can treat this with therapies, and we kind of consider this a reset button, or we wipe the immune system clean again to allow for the organ to keep working. The majority of this conversation will kind of focus on our maintenance therapies moving forward. So, we're mentioning all these different medications. You saw the blue boxes. So let's look what are some of the ingredients we have in that pizza. So the first transplant took place in the 1960s. We saw, the main backbones of these were a medication called azathioprine and steroids. We still use steroids today in transplantation, but the doses of steroids that were used back in the 60s were whopping doses that gave people a lot of side effects. Beyond just the side effects that were caused by these early medications in the days of early transplantation, we saw that the grafts or the new kidneys were not working for very long, and only 50% of them made it to 1 year. And in the early days, if even that, and we saw the new kidneys failing within a month. And that really pushed the community of transplant to do better. And what new medications can we produce to give our patients better outcomes? And with this, we saw the development of all the things that you're seeing on this timeline. I would say the 1990s was a hot decade for transplantation. We came out with a lot of the medications that we use today. I would say the two most common medications that I start the majority of my patients on would be tacrolimus, which came out in the early 90s, and mycophenolate mofetil. So two medications that you see we're still using today in and out on all of our transplants. We had other medications that play roles in induction and desensitization and rejection therapies, and that's what a lot of these medications that have come out beyond this. As you can see here in red, we've improved graft survival significantly, and 90% of our grafts or new kidneys make it to the 1 year mark. So really now the focus has shifted to how do we make those grafts or new kidneys live far beyond a year and make it to 5, 10, 15-year marks. And with that, a lot of focus has been on how do we prevent rejection and treat rejection effectively. And that's what's led to these newer therapies. So when we think about immunosuppression, we talked about how this is really a pizza and what works best for you. But there are some general principles that will always remain true in immunosuppression. First and foremost, we always have to have our backbone agent. The guns that are carrying the majority of the work in this. And I think the best way I can describe that is our fellow friend, Mr. Batman. Batman, is really necessary for stopping crime and really is the face of his community and has a lot to carry on his shoulders. Then we also have to have an adjunctive agent, that being Robin. Batman would be nothing without his sidekick, and there is no way he could stop all crime without him. So we know that we need both, and this is the only way that we can effectively prevent rejection. Additionally, got to give a shout out to my ladies. We might need a Batgirl to help us out. And this, some centers choose to utilize and other centers don't. And it also is organ specific. But it's important to remember that you may need 3, but a 2-piece regimen is definitely imperative. And all of this together can effectively prevent rejection. So I think that's a really important concept for someone going into transplant to understand that when we say we're going to start anti-rejection medications, it will never be one medication, and that it will at least be 2, maybe 3. And keeping in mind that really those medications are working in different ways, and it's important to take all of them all the time. So what are some suggestions, or what are some examples of what our backbone adjunctive and potentially additional agents? So first and foremost, I told you guys that tacrolimus is one of our mainstays in therapy. So a backbone agent is definitely going to be tacrolimus. Probably, I would say, my right-hand man, but I'm reaching for the most often. If you were to have side effects or anything from tacrolimus, we might lean towards cyclosporin. Other options also include our sirolimus and everolimus that might carry some of the weight. And then lastly, we can see belatacept, that new medication that's IV or intravenous, infused once a month. That can be a medication to do the majority of the heavy lifting. It's pretty rare that we would see people on all 3 of these backbone agents, or even 2 together for a long, substantial period of time. But like I said, never say never. You know, people these days put ham and pineapple on their pizza, so you never know what goes into your pizza recipe. Additionally, for our adjunctive agents, we see that we can have mycophenolate. I would say this is probably about 90% of kidney transplant patients are maintained on mycophenolate, most often paired with tacrolimus. But sometimes people experience pretty bad side effects from this, and we're willing to switch it up. Maybe we'll consider azathioprine, or borrowed from the backbone, we might be using sirolimus and everolimus at different doses. Never want to forget about our Batgirl, who really can come in handy a lot of the time, and that is sometimes we'll add on prednisone, a steroid that we'll use in lower doses, typically 5 to 10 milligrams a day, to act as maintenance immunosuppression for our kidney transplant patients. So, you know, I really focused on how, yes, these are great drugs. We have gotten as a community very good at preventing rejection. We have found ways to make our grafts make it to that 1-year mark time and time again. But don't forget that I did say that these are a necessary evil, so there must be some negative to them. And this negative is something that we could mitigate and help prevent and help treat. And it's always important to talk to your doctor, your pharmacist about these negative side effects, because often we can find a way around them. But the most important thing to remember is knowledge is power, and knowing what are some of those side effects that we see. So with our CNIs, which are also called our the tacrolimus and cyclosporin are considered CNIs, we can see a lot of pretty terrible side effects. We can see kidney damage, like also known as nephrotoxicity. We can see it causing problems with memory, and we can see it causing higher blood pressure, diabetes, higher lipids or cholesterol. We can see changes in hair growth, and sometimes problems with gout. And none of this is to scare you, it's just to make you all aware of what are some of the side effects and how can we help prevent this. The thing is, us as a transplant team are very, very aware of these side effects. So we are constantly trying to minimize the amount of medications that we're using and minimize the doses we use them at, all in efforts to prevent this or to help treat this. With our mycophenolate, we can see GI toxicity causing some nausea and vomiting and diarrhea. With our steroids hidden in the background there, we can see some diabetes, weight gain, body changes, glaucoma, and issues with wound healing. With our sirolimus and everolimus, we can see some edema, hyperlipidemia, which is to say an increase in your cholesterol, protein spilling into the urine. Most notably, I would say mouth ulcers are one of the side effects that's caused by this medication. And then with our belatacept, sometimes we can see infusion-related reactions or a cancer called PTLD far down the line. So because all of these side effects are so significant, this is one of the main drivers in why we are using these medications in combination. When we're able to use these medications in combination, we can reduce these side effects so that they are not experienced by the patient at the best, acceptable way we can do this, and kind of maximize their efficacy. So we're always trying to find ways to minimize the toxicities that any of our patients see and maximize the efficacy that is experienced to allow for a long-lasting new kidney. And I would say my drive home point would really be remembering to communicate with your transplant team so that we're always aware of any side effects that you are experiencing so that we're able to change it for you. So knowing all of this, I've told you a little bit about how there are some toxicities associated with these medications. I would like you guys to remember that we constantly feel like this little man on the center of a hot plate. We're trying to avoid the toxicities, but also not get too close to the red zone of rejection, potentially causing harm to the new kidney. We also don't want over-immunosuppressed patients who are constantly getting infected or long-term having cancer. So this is a constant battle and something we're constantly running through our minds of how do we make this the best thing possible for our patients. And so that always leads to the question, which combination is best? And you'll talk to someone, I work at UIC or University of Illinois. You can go to the University of Chicago, you can go to Northwestern or Rush, and every center truly believes they have the perfect protocol that has really optimized results for patients. But across the map, we don't know right now what the best immunosuppression regimen is. We know that one of the biggest things to keep in mind is that we have to make this specific to the patient. No longer can we paint with broad stroke brushes to say that every patient should get all the same medications. If you take into consideration, we have 253 transplant centers in the United States, and all of these centers think that they have the best protocol. That leads to quite the hodgepodge of regimens. As you can see, I have stacked here on top of each other. And one thing we constantly ask ourselves is it easier and better for the patient to take less medications, meaning we give them 2 medications and run them at higher doses and feel confident that this is preventing rejection? Or should we do a sprinkle of 4 different medications to prevent rejection because we are using smaller doses or smaller quantities of all 4? And really, we don't have that answer just yet. And so what do we base this on? We base this on you, the patient. We always want to bring that back into, we have a starting block, but where do we go from here with how the patient is experiencing side effects and potentially experiencing rejection? So I think I've really driven this point home. The best way to optimize immunosuppression is by individualizing this to you. We always are considering, like I mentioned, that little man on the hot plate, running away from toxicity, running away from infections, running away from rejection. But we really have to, we think of that on a global scale, but then thinking again about you, the patient. We want to remember, has our patient experienced rejection? Are we more scared of rejection because we've seen it once before? Are you, the patient, experiencing, higher blood pressures and higher blood sugars? Do we need to back down because you're experiencing some of the negative side effects of this medication? Are you a patient who really struggles with a twice-a-day medication? We are here to help you with that, whether that be with pill boxes or apps like Dr. Valdepenas is going to talk about, or is it just easier for us and you in your hectic life to only take a medication once a day? And that might not be possible with all regimens, but we can try to optimize to the best of our ability. Additionally, we have to think of you as a patient as a whole, not just your transplanted organ, your new kidney. We can't just think about that. We always have to take into consideration, What are your other diseases that we need to be aware of? Have you had a heart attack before? Do you have diabetes and high blood sugars? And how do we help make sure that those diseases don't get out of whack just in name of the kidney? And then lastly, we always want to be thinking about the risk of infections to our patients. Are you frequently coming in with a urinary tract infection? Maybe we need to revisit your immunosuppression, because I can't stress enough how intertwined all of these pieces are. And this is probably one of my favorite quotes. I'm surprised it wasn't said by a pharmacist, to be honest. Drugs do not work in patients who don't take them. And so this is such an important point. We can come up with the perfect regimen, which we know will lead a kidney to work for 20 years, but if the patient's not willing to take the medication, whether that be because it's way too hard to take, like something that's 6 times a day, or because it causes a side effect and you just feel like your stomach's hurting the entire day on the medication, then this medication doesn't work for you. And really, I can't stress enough how much adherence or taking your medications as prescribed, as you were told, and kind of conversations with your doctor matter, particularly in transplantation. I saw a statistic that said at least 23% of transplant recipients don't take their medications as prescribed. And there are articles that will list numbers as high as 67%. And I truly see this in clinic. We will see patients come in who say, I always forget to take my afternoon dose. And although it might feel like it's only happening a couple of times a week, over time, that can get us into some really big trouble with transplanted kidneys. So always important to really stick to your medications in the way that they were prescribed day in, day out. And the best advice I have to patients who are not yet at this transplant point is to start now. Start getting in those good habits and really understanding, how am I supposed to be taking my medications? What are each of my medications for? And how can my doctor and pharmacist do a better job at educating me so that I can feel better equipped to take my medications as prescribed? When we look at how do we define non-adherence, there are certain risk factors that will really put our patients at higher risk to not take their medications as prescribed. We see socioeconomic factors play a role, with younger age, male gender, lower financial status and lower education level having a negative effect in patients being less likely to take their medications. We also know that health beliefs and behaviors can play into aspects of taking your medication. If you don't believe that this medication works for you, or you don't believe that high blood pressure is something that will cause damage to your kidney, then that will more than likely increase your risk of not taking your medications. I would say one of the biggest factors is our treatment-related factors, like patient symptoms or side effects. If patients are experiencing side effects that are debilitating or life-changing, there is a really slim chance patients are going to take this medication as they are supposed to. And then something we're really seeing play out right now is a lack of health insurance or underinsured patients with a lack of healthcare benefits. It's impossible if you go to the pharmacy and your medications cost $600 a month for that to be something that's sustainable. So really talking with your social care, your social workers and insurance, speaking with what plan is best for you. These are sometimes things patients will tell me that they think about their medications, particularly their transplant medications. I have a lot of patients who will say, when I present to them, you're going to be taking 10 to 12 medications immediately after the transplant. A lot of patients will feel really empowered that they get to take control of all these medications and really set things out for themselves. But on the opposite end, we'll have a lot of patients who are so scared of missing a dose or not understanding the medications, or really having a fear of the mass quantity of these medications, and that can drive problems with their medications as well. We also see managing regimen demands, especially in those first 6 months post-transplant. We'll see patients having to take certain medications up to 4 times a day. And that can be really, really overwhelming, particularly if you don't have support from family and friends. So really establishing good habits now is very important. A lot of times after transplant, we have people who feel that their life is just over medicalized. And that's really understandable for patients who have to come to clinic twice a week in that first month after a transplant. And the biggest encouraging thing I can say is that this is, if you do take your medications and follow up appropriately in those first 1 to 3 months, life gets a lot easier. But a lot of people will feel driven by this social accountability and motivation. And I always like to brainstorm what are ways that we can help as providers. And some of the things I've read and really tried to implement into my practice is always increasing the patient's knowledge as to why you're taking this medication. Like I said, knowledge is power, and if you fully understand the significance and the importance of taking these medications, you'll feel more driven to take these medications. We also see that developing a system of reminder cues works really well for patients. I have some patients who they'll take their medications right after they brush their teeth, because brushing their teeth is a reminder for them to take them. And that works really well, and knowing what works well for you. I think this is the third point of involving family members and or friends as a support system is not a strategy, but something that's necessary. You can't do this alone. This is incredibly, this is a life-changing moment. A lot of people say that their transplant will be like a new birthday for them, and it's very important to take that into consideration. We always want to try to simplify the regimen as much as possible, and then work together to, when these current strategies aren't working for patients, and see if we can make it easier. We always want to be providing constant education, particularly about the necessity of the anti-rejection medications, especially when life happens. So we pose to you, unfortunately we don't have an audience today, but I do want you guys to think of what are ways that help you remember to take your medications, and can you establish these as a more frequent reminder or recurrence that happens in your everyday life. And with that, I'm going to turn this over to Dr. Valdepenas, and he's going to be discussing some of the ways you can help remember to take your medications.
Thank you very much, Dr. Anesia Reticker, and I think Dr. Reticker has pretty much laid out to us a very, very clear framework as to how these immunosuppressants or anti-rejection medicines work, the advantages, the disadvantages, and the importance of medication adherence. And I'd like to go back to the quotation that Dr. Anesia Reticker mentioned. These are wise words of former US Surgeon General C. Everett. He says, drugs don't work in patients who do not take them. And that's quite telling, that even if we come up with the best medication to prevent rejection, if you, our patients, don't take them, these medications are all for nothing. The World Health Organization estimates that adherence to long-term therapy for chronic illnesses in developed countries, such as the United States, is only around 50%. That means that for every 10 transplant patients, 5 of them may be missing a dose or having adherence issues in one way, shape, or form. And so as a transplant pharmacist and as a transplant pharmacy resident taking care of transplant recipients, being adherent to medications is true and real challenge. For one, it is estimated that the kidney transplant recipient on average takes at least 8 medications. Now, if you were to ask me, that's a lot of medications. And so our goal as transplant pharmacists is to assist our transplant patients on how to remember to take their medications. And more importantly, we try to provide tools to empower you, our transplant patients, on how to take ownership in managing your medications, ultimately managing your life and well-being. Some traditional adherence strategies or tools to help us remember to take our medications include the use of pill boxes. A lot of our patients use pill boxes with 4 different time slots to help them remember to take their medications. As part of discharge education, a lot of transplant centers would require transplant recipients to be able to fill a pillbox prior to being sent home. Keeping medications in key locations in the house is also another strategy. Patients I see in clinic would often say that they keep their medications in their nightstands to help them remember to take their medications. Just be careful that these medications should not be accessible by our terrible twos or young children. While we are on a social lockdown nowadays, it is just as important to bring your medications with you wherever you go, whenever you're traveling or having a long trip. And finally, phone alarms, setting alarms to remind you to take your medications. For our pre-transplant patients listening in, these strategies don't have to start after transplant. I always advise our transplant candidates to start practicing adherence, good adherence practices as early as now, before transplant. They say it takes 6 weeks to change habit. I say the earlier you do it, the better. With the advent of smartphones, Android phones, and iPhones, we have our new generation applications that we can use to improve medication adherence. This include MediSafe, Care for Today, CareZone, MedPal, MyMeds, Mango Health, and finally, Round Health. For the sake of this presentation, we would be going over MediSafe, Mango Health, and Round Health, pointing out the important features of each application. For our young at heart patients, these applications are very easy to navigate and very intuitive. If you need help setting up the applications, we, your transplant pharmacists, will be very willing to help you set this up. You can also have this opportunity to ask your more technologically savvy children or grandchildren to assist you, and this may well become a bonding experience too. The first app that we're going to talk about is MediSafe. MediSafe is probably one of the most popular apps, and it's a free app that is very self-intuitive and has a number of features, including medication reminders. It has good patient education videos that you can watch, refill reminders to remind you to refill your medications and call your pharmacies for a refill. It has a MediFriend option who can help monitor and encourage adherence. So you can actually recruit a friend, join the app, and have some sort of moral support and encouragement by having this MediFriend. Checking drug interactions, looking for good RX coupons or discount, and tracking important measurements such as weight, waist circumference, your hemoglobin A1C for our diabetic patients, blood glucose, your kidney numbers, serum creatinine, blood pressure, and much more. Finally, you can also input your doctor's appointment. So it can also act as a reminder when you're going to see your transplant nephrologist, when you're going to see your transplant surgeon. It can also integrate with your smartwatch for those of our patients who have smartwatch with them. And finally, some health systems can import data to their electronic health record. So this MediSafe app is really pretty much an all-encompassing app that can do a lot of things for our patients. The use of MediSafe app has also been shown to have positive, impactful outcomes, including controlling blood pressure, lowering stroke, and cardiovascular risk. So it's one of those apps that's actually been studied, and it has been shown to have favorable health outcomes, particularly affecting, our patients with blood pressure in terms of lowering their blood pressure by at least 20 millimeters of mercury and lowering cardiovascular risk and other cardiovascular or heart-related diseases or disease states. The next app that we're going to talk about is the Mango Health. This app allows to track medications with alerts. It also has tracking abilities with certain measurements such as your weight, food intake, blood pressure in similar manner that the MediSafe app has. The most unique thing about Mango Health is actively recording your medication taking habits, and as you record them, as you record that you're taking your medicine, you actually earn points. And when you earn points, guess what happens? You can earn a prize in by gaining, for example, or earning gift cards. So this news article from NPR has actually featured Mango Health and how people can earn prizes through gift cards by just taking their medications. The last adherence application that we're going to talk about is Round Health. Round Health is also a free application, but the downside of it is that it's only available in Apple devices. Round Health is a medication and adherence tracking device that sets a window of time to take your medications that increases in notification intensity. For example, you have an hour leeway to take your medication, and as that 1 hour time leeway comes, the notification intensity increases. This app can also be synced to an Apple Watch device. This is only available once again in Apple devices, and it's a free application that allows for medication reminders. Other non-medicine applications that we can use to stay on top of our health and our medications include our MyFitnessPal, Apple Health, and those of you who have smartwatches with them, you can easily integrate these watches to these applications. I'd also like to point out some good resources for our transplant patients and our future transplant patients about these resources from the American Society of Transplantation and the National Kidney Foundation. Both of these organizations have very helpful patient education packets, patient education videos created by experts in the field that you can use to educate you, to give you knowledge and wisdom about how it is to become a transplant patient. As Dr. Reticker well mentioned and well articulated earlier, knowledge is power. At the University of Illinois Hospital and Health Sciences System, where I work, the major medication adherence and memory tool that we use is a medication list, such as this one that's posted in your screen. The list is structured in a manner that goes over the names and strengths of the medications, the common side effects to expect from the medications, and finally, the approximate times that these medications are supposed to be taken. So this is what we use at UI Health, and if you're this type of person who can easily rely on a medication list, then feel free to make your own medication guide in paper. Other services that we can utilize to improve medication adherence and make sure that our patients get their medications include medication therapy management clinic. Here at UIC, we are very, very fortunate to have a robust pharmacy service. And one of those services that we provide is this medication therapy management clinic. It's a pharmacist-run clinic. So what happens is that these patients, whenever they come to clinic, they see their pharmacist, and we spend a dedicated time to make sure that we go over the medications with our transplant patients, going over each and every medications, how to take them, and help them fill their pill boxes. Another service that we can offer is this medication assistance program. Again, here at the University of Illinois at Chicago, we are quite fortunate to have a robust and productive pharmacy service, so we can actually assist our patients in terms of ensuring that if the medications become unaffordable, that we can assist them obtain different types of financial supports, whether it be to medication vouchers, in order for our patients to be able to take their medications. Finally, in conclusion, medication adherence, pretty much this is, the focus of the latter half of our discussion today. Medication adherence is really a multi-pronged issue that needs to be attacked from all sides and all angles, using different approaches and strategies, not only to increase and improve medication adherence, but also more importantly, very important, to empower you, our patients, in managing your medications and your health, making sure that you, our patients, and your families are involved in managing your medications. As Dr. Reticker mentioned earlier, it actually takes a village. This doesn't have to be your own single journey, but a journey of your family, you, and other healthcare providers that's taking care of you, including your doctors, nurses, social workers, and us, your pharmacists. Also, front and center to this issue is making sure that you, our patients, can afford and obtain your medications, particularly in these trying times of economic uncertainty. Now, with that brings us to our next topic, immunosuppressant drug coverage updates. So let me pose this question to our viewing audience. How are you paying your medications? Are you paying it using your employer-based insurance, your market-based insurance, Medicaid, or Medicare? When I think of the US healthcare system, and when we think about our payer system, particularly in our US healthcare systems, I think of these 4 buckets. You may be paying your medications through insurance that is obtained through your employers, through your jobs. Or you may be paying them through this market-based insurance or through this exchange that you've heard about during President Obama's time. Another way where you may be paying your medications is through these state initiative Medicaid. So Medicaid rules and regulation varies from every state. So for example, for Illinois, you have to meet a certain income or poverty cutoff. And finally, and this is probably how most of you are paying your medications, through Medicare. Now, it's interesting that if we look at the history of Medicare and how it helps us pay our transplant medications, in 1983, Congress passed this bill that only allows for 1-year coverage of medications after transplant. So that means to say that in 1983, if you got a transplant in 1983, Medicare would only cover transplant medications up until 1984. And that doesn't make sense, right? We gave you a new kidney, and we hope that that kidney lasts for a long time. And the way we protect that kidney is by giving you medications called anti-rejection medicines. But it doesn't make sense that we only cover the anti-rejection medicines coverage for 1 year. And so finally in 1993, we were able to extend the coverage up to 3 years, so up to 36 months. So it's an improvement from 1983 up to 1993, but still that doesn't make sense. What makes sense is to have a lifetime coverage, particularly covering the anti-rejection meds for Medicare to cover them lifetime, lifelong. And so that's been an ongoing endeavor for our lawmakers, for our organizations, the National Kidney Foundation, the American Society of Transplantation, working with the Senate, with our lawmakers, to extend this coverage, this medication coverage, not just for 3 years after transplant, but more so for lifetime. And that's where this Immuno bill comes from. This Immuno bill is a comprehensive immunosuppressive drug coverage for kidney transplant patients, and it's an act that would extend Medicare coverage of immunosuppressive drugs for transplant recipients past 3 years, hopefully for life. And so we encourage you, our patients, in order for us to be able to achieve this, we encourage you to contact your lawmakers so that we can put them up to speed in terms of passing this bill and ensuring that we can extend the coverage of your medications by Medicare, not just for 3 years, but hopefully beyond 3 years and at best lifelong. I would encourage you to visit this website and to fill in your address, and it will actually direct you to fill out a letter, sending it to your lawmakers so that they can act on this bill promptly and swiftly. And with that, I'm going to end my piece. I would like to thank the National Kidney Foundation of Illinois for giving us the opportunity to speak to our transplant recipients and our future transplant recipients, educating them about their medications. Just some final thoughts again. Most of the current literature being investigated in the transplant relates to medication adherence. Again, the point being is that we can come up with the best medication strategy, but if you do not take them, this all goes for nothing. Adherence to medication is an important factor for transplants to maximize their lifespan and to avoid complications. And finally, the best approach to optimize medication adherence is teaming up with healthcare team to find a customized strategy that works for you. All of these things that we're coming up with, all of these things are gonna fail if it doesn't work for you. So at the end of the day, it all goes back to you, our patients, and this has been well stressed and emphasized by my colleague, Dr. Anesia Reticker. Once again, I'd like to thank the NKF, and we also would like to thank some transplant pharmacists who helped us create this presentation. Drs. Alicia Likvar from the University of Illinois, Dr. Maya Campara also from the University of Illinois, and finally, Dr. Lisa Potter from the University of Chicago, who shared their thoughts so that we can come up with this good presentation. Thank you very much, and you all guys be safe and be well.